We've had just such a wonderful day of really incredible information. And not to be outdone, but we have a very dynamic panel here ready to go. But before we begin, I just want to get a AO from everyone. So, is everyone happy to be here? AO! Okay, just a little bit more. I know that's that coffee afternoon thing is just setting in. I have to really, really feel it up here. I want this panel to be energized by all of your AOs that's coming. Are you happy to be here? Ayo! Panel, we look like we're ready. So we are going to start the introductions from one end, and each person will be introducing themselves as the microphone goes on. So I give you your first panelist.
Aloha, everybody. Um, my name is Richard Taff. I'm the CEO of the Hawaii Island Community Health Center, which is island-wide, thank God.
Hi, everyone. My name is Clayton McGann. I'm the CEO for the West Hawaii region, HHSC. So that consists of Kona Community Hospital and Kohala Hospital.
Good afternoon. I'm Denisha Lagapa. I'm the VP of Ambulatory Services for Kaiser Permanente.
Aloha, everyone. I'm Stephanie Violetti. I'm the president of Queens North Hawaii Community Hospital.
Aloha, everyone. Susan Mochizuki. I'm Executive Director of Big Island Docs Independent Physicians Association, also known as East Hawaii IPA. And no, that's not a beer. And manager of Big Island Healthcare Clinic.
Well, aloha and good afternoon. I'm Dan Brinkman, so I'm the CEO for the East Hawaii region of HHSC, and that's now Hilo Benioff Medical Center, a change from last year, and Ka'u Hospital, and now Honoka Hospital, which used to be Halehola Hamakua, and who went back to their original name of Honoka Hospital. We also have the Veterans Home, which is located in Hilo.
And I'm Eric Shell. Again, sorry. So I've been asked to moderate this crazy cast of characters up here and to ask questions of them. And so the work group, over the last couple of weeks came together with about 6 questions. And want to get both their individual perspective as well as their system perspective. We spent a lot of time this morning talking about my talk and then Jack's talk, kind of all around evolving, how the healthcare system's evolving. And so one of the first questions that we wanted to ask, I need 2 hands to look at my phone, so I'm going to hand the phone over. Well, no, I can't. All right. We're going to start with Dan. He's the one. So Dan, how do you see healthcare delivery evolving on the island of Hawaii? It's not too open question, is it?
That's really a tough one. Thank you for the question, Eric. I've known Eric a long time. It's interesting having talked with him on a number of occasions that when you talk about it, healthcare evolving, I guess some of the thoughts I have is that it doesn't evolve very much. And I think that actually is a reality, that it changes very slowly. It seems like many of the issues we were talking about today, we talked about last year, we talked about 10 years ago, the exact same issues. And the change is very incremental and it's frustrating. And how do I see it evolving? I think it's going to evolve slowly. And I think it requires persistence and perseverance and doing things like this where we try to build relationships and improve things where we can and be very dogged about doing it. And if we make steady progress, even if it's slow, it'll get better. But I don't think there's a magic solution, and I don't see it evolving very quickly, but I believe that this group can make it better.
Same question, right?
Same question.
Okay.
Yes.
Well, I come from an environment that used to be a network of Dr. Marcus Welby's. I don't know if many of you remember, maybe some of you are too young to remember Dr. Marcus Welby, but a lot of solo independent practitioners. Kind of harks back to the plantation days where you had those individual solo practitioners serving their smaller communities. And in the 10 years that I've been on Big Island, I've actually seen a lot of evolution, and in terms of retirements, in terms of not seeing a lot of primary care providers that are younger. And so little by little, actually in the past about 6 years, there's been a 50% decrease in the number of independent providers. So I've really seen that change. And to me, that was pretty fast because we're talking thousands of patients without PCPs. And so in terms of the evolution of that, I think we're seeing more consolidation. We're seeing some practices wanting to form groups, also hiring APRNs and PAs to support them doing team-based care. And of course, the payment model for a lot of our primary care doctors has changed to actually going a little bit toward the value-based model. And little by little, we have seen change in things like technology. And I know some of our docs are kind of slow to adopt EHRs and so forth. We actually have one member who's still on paper, but pretty much everybody else has transitioned. So I'm kind of optimistic about the future in that sense, that little by little we are seeing some change, but probably the change in the system cannot happen fast enough right now. Thanks.
Let me know if you want me to repeat the question.
No, I got it.
Okay. All right.
So I just want to say, I just moved to Waimea in December. And I just want to say, I'm very, very grateful and honored to be able to do that work that I'm doing on the Big Island. So mahalo to all of you for welcoming me. I have not been in healthcare for the last 5 years. So I was in energy for a few years and working for a little nonprofit, focusing on legislation to make Hawaii more affordable. So I have this, and I'm just gonna riff off of Susan, this sense of urgency. And I know Dan said, it's slow, and it's been 7 years since I heard Eric's presentation about the shaky bridge. And I feel it every day. It is painful. And I know all of you agree. It is painful in so many ways for our patients, for our communities, for our providers, everything from oncologists to our PPAs. And so what do we need to do differently to get us to move faster? Because I don't know how long, in every position, that people can continue doing this work, this very, very hard work that's just painful every day. So social determinants of health, how do we address that? Because that's a huge piece. We want to get here, but we're still in heads and beds, fee for service, right? So productivity, all of those metrics, but we want to get here. So I guess if there's anything that I want to emphasize is that I am hungry, I am anxious, I'm excited to move.
Thank you. So I'm going to take a different approach, and let's just put ourselves in the eyes of a patient. I'm a 35-year-old, I wish, 35-year-old pregnant, and I live in Puna. And I have to travel so many miles to get healthcare. But my healthcare now offers me a program called KP Connected in Pregnancy. And when I go into that visit, they set me up with a scale. They set me up with a blood pressure machine. And as long as I meet those qualifications, I can take that home and I can do my care at home, so I don't have to travel in as frequently. They're making it easy. this is where we want to go. We're not there yet. We have trialed this in some areas, but we absolutely are not there yet. But that's how I envision that healthcare on the island of Hawaii evolving. I have to say, the COVID pandemic that occurred a couple years ago, there is a silver lining in that. It caused our nation, it caused Hawaii to do things differently. It forced us very quickly to do things differently. And leverage technology was one of them. So there is an issue, and I know we'll talk a little bit about that. There's some barriers on this island in terms of digital access. But it is something where we need to look at it when involving healthcare, is we need to have some platform and a framework. It needs to have clinical evidence. We need to have community partnership. We need to leverage technology, and we need to be member focused.
Clayton, don't start with you're a 35-year-old female president.
I'm not. Well, I thought about it. I might. No, I actually agree with everyone. It's really tough to think about this, but when you see what's happening on Hawaii Island, I think that there's a lot of hope. And I would say that because the legislators are now recognizing the need on the rural islands. They come more often, we're engaging them. And so I think that that's one of many steps. I also see a lot of effort, and it's shifted significantly with collaboration and care coordination. And I think that that falls into the payment models that you discussed earlier. It really comes down to, and especially here in Hawaii, we are a healthcare system of many systems, right? But when you look at Hawaii in general, it's a culture where everyone comes together for the same purpose. And I see the evolution actually changing, where you're seeing more and more of that. I mean, this is the second conference we've had, and it seems to have grown since last year because more people are interested in how we solve these issues. And to me, I think that there's a lot of hope there. So.
Thank you, and I would agree with most everything. And I love your perspective as taking it from the patient perspective. I'm not convinced from a patient perspective they've seen a whole lot of evolution. They still are challenged to navigate that system, that diagram that was put up by Judy about how to navigate the system. It's still very, very complicated. But if we look at it from our perspective as a healthcare provider, I'm going to look at it from the Hawaii Island Community Health Center. I think we've evolved quite a bit. We've done a merger, so now we're island-wide. We've brought on Epic, which has been tremendous. Our care coordination, our ACO, and the integration of behavioral health, medical, and dental, that's been a huge lift, but it is the right lift. And I think that healthcare has become a very complicated system, much more so than in the past. And I mean, I remember, I won't say how many years ago, it was a lot less complicated, but there's a lot of regulations, but it goes back to, I forget who made the comment, it's about relationships. And that's what's evolved and evolving here today with this group. Is the evolution and building of we're creating relationships that will allow us to move forward and to make changes. So I think it's a combination of things.
Thank you all. Good news is we have 5 more questions. And then we'll open it up to you. So this morning we talked about this thing right here that none of you could read outside of the first row, about kind of as payment evolves, form and function of your individual organizations to some degree has to evolve to meet a changing payment system. Right? And so the next question is, what is each of your organizations' approach strategy to value-based care, and how will you be deploying this locally?
guess since I have the mic, I'll
got
start
it.
at this end and we'll work it back.
And let me know if you want me to repeat the question, because there was a lot there. Oh, nice.
Um, For our organization, we're in the throes of moving from volume to value. We have a plan and a program, and we're negotiating with the health plans right now around going to alternative payment methodologies. We're even having some conversations around some global payments. We're in an ACO, because we've been in it for a while, we're on the downside risk, so we're looking at downside risk, the ACO. So I would say we're quite a ways along. There's still a lot to do, but over the last 5-6 years, we've moved the organization in preparation to getting to value-based, which talks about quality of care, outcomes, closing patient gaps, care coordination, reducing hospital readmissions and ER visits. And we've had quite a bit of success with a cohort of about 500 patients in the last couple of years to actually reduce those two metrics, the hospital readmissions and ER visits, significantly, and we're very much lower. So I would say we're on that trajectory. We want to move in that. We know that, and as I've said, when I go talk to some of the health plans, if we keep on doing what we've always done, we're going to keep on getting what we've always got, and I'm not happy with what we've got.
What's fascinating about that response was that we talked about in that transition framework, this thing, the need to simultaneously address from a strategic perspective, proactively picking up moving payment, creating healthcare, that was the blue bar in the middle, and transforming our sick care delivery system. What was interesting is I heard you talk about really picking up and moving payment. And then what followed was the beginning of the creation of the healthcare system, that crawl before you walk, before you run. And so absolutely fascinating what you guys are doing. Mr. Clayton?
We're still crawling, unfortunately.
Crawling.
But we're extremely focused on quality. And that was part of your framework, right? Quality over cost, because it hasn't always been that way. And for us, that is our main focus right now, is quality-centered patient care. How do we make sure that we're not just the only option for someone to go to, but we are the option that they want to go to because of the care we deliver every day? Shows not only the patient, but their families that we can be trusted with their healthcare. So that's what we're focused on in West Hawaii.
Do you see that advancing? How do you see, okay, so let's just say you check the box on quality. You check the box on quality. Where will you go next?
You know, it's the payment models. How do we now work on outpatient and focus on bringing the care outside of the hospital, right? I'm a hospital CEO, and I'm trying to make sure that we keep care out of the hospital, because that's where the payment models are going. So that's where we'll go next.
Thank you. I'm interested in what you got to say.
So I appreciated your session where quality, we need to increase, affordability, we need to decrease, and we need to apply it to the population. So at Kaiser Permanente, value-based care is a top priority. We are not there yet, but we are moving fast and furious towards driving towards that. We, on the island of Hawaii, we provide 20 different specialty departments and about 60 specialists we either bring in to service our members, or we have we fly them to Oahu, because we know that is how they define value, right? It is also making sure that from a member's point of view, what does value mean to them? And you're right, value may mean leveraging technology, or it may mean, a kupuna who don't even want to go near a phone or a computer, or they don't have access where they live. And so how do we define that? So I think for value-based care, it is making sure that it is uncompromising quality. It is making sure that we are evidence-based and clinically sound wherever we are practicing, and we don't compromise in that, and making sure that there is patient satisfaction in that. We have really embarked on leveraging centralized services, digital technology, and just dabbing in what is the appetite for the community. And it will vary, it'll vary within the state, but just on this island alone in the geography, it varies. And that's where we need to be flexible.
Thank you.
So I'll share a story about the dream of working together. So when I worked at Kohuku Medical Center in Kohuku, right across the street from us was a federally qualified health center, Ko'olauloa Health Center. And they did primary care. We didn't do primary care, but then we did. And we opened up a rural health clinic. And it divided the way that we did healthcare. And it saddened me that we couldn't figure out how to work together to meet the needs of our community. Instead of looking at competition, what could we work on collaboratively? Shared services, shared staff, all of that. I definitely think there's movement forward, but it's taken a long time. I think the population of the Big Island is 200,000 residents. There's definitely opportunity to be able to come together and contract with our payers for 200,000 residents. Because right now, all of us, in hitting our quality metrics, takes a lot of resources. It has to go through data warehouses, the data has to get sliced and diced, and people have to be assigned to keep track of all the data and who's doing what, when are they doing it, who's reporting it. There's a lot of resources that go to that. So I think that's one opportunity. How do we move that?
So,
Go.
so what question are you answering?
I'm just throwing out different ideas.
Oh, okay, okay.
Yes, and where we need help.
Sorry. She knows me.
Yep. I've known Eric a really long time already.
Yes.
So I think a place that we need help is this whole thing. If we're going to address social determinants of health, we need social services and healthcare providers. So if I have a patient that's coming in and needs help with drug, outpatient drug treatment, I'm going to make a referral to BISAC, right? But how does that referral get made? So I'm just sharing where Queens is looking at Unitas platform. I'm using this platform to share that I'd love everybody to get on the Unitas platform. Because then that's how the referral process, that's how we close the loop. That's how we track the data. That's how we service our community, is by utilizing one platform. Because right now we're still using it. I start off as a social worker, faxing referrals, calling referrals, emailing referrals. We still do that today. We're not tracking any of that data. So I'm putting a plug for that.
So in other words, North Hawaii Queens approach to value-based care here on the island is first pulling patients into the system so you can start tracking their data.
I see what you're doing, yes. So our QCIPN, so I want Mia, can you stand up? Mia Taylor, she's back there. So she does our care coordination for our system and for our physicians, providers, right? So she's our kind of go-to person. And that's the next evolution, is being able to have this referral platform. Okay.
Okay, thank you. Awesome.
Okay, well,
Watch it. I could ask you a really hard question.
Oh, yeah. Oh, same question, right?
No.
Oh, okay.
Yeah. Yes. Same question.
Okay.
We're in question
Yeah,
number
I'm still on
2.
that same question.
Let me ask the question again for all of you out there, because here's what we're answering. What is your health system's approach strategy to value-based care, and how will that strategy be deployed on the island? So that you all remember what we were talking about.
Okay, I'm very proud to say that our association was the very first, it was called Model Office 10 years ago, and we went into capitated payments, payment transformation. So we were the beta for this. For the commercial population, it was a hardcore group of our independent doctors, and it took a while, They had a lot of training, a lot of sessions, but after a few years, they said, we are never going back to fee-for-service. They just saw the benefits of it. And so HMSA said, hey, let's roll this out statewide. This is a cool thing. This group really succeeded, and it was a small enough group so that we could, so that we could measure and we could get feedback and so forth. Since then, unfortunately, the program has not really evolved, and so it isn't achieving exactly what we all hoped it would. Part of it is there isn't that upfront investment in the kinds of services that you need to really work upstream to keep those members out of the hospital, to provide that care, to prevent ER visits and so forth. And so we sort of have one leg of the stool, but we don't have the other parts. And so I think that's where it needs to evolve. Now, our independents they're a scrappy bunch of guys and women. And they go out and try to seek favorable contracts. So they went out and got some grants from CPC Plus, and then working with the larger Oahu systems to get on various ACO contracts. And a lot of those are just short term, but hey, it's extra capitated money, it's money in the bank, and maybe they can hire an additional MA to really work on those measures. The quality program, it has really, for the majority of our independent docs, has been well established, again, thanks to our friends at HMSA. We love them, and sometimes we hate them. I don't know if there's Kenrick left or not, but anyway. So I think we're making good progress. We're hopeful, but I think we do need a more consolidated effort to really move the needle where it needs to be.
Good stuff. So when you talk about capitated contracts, was it capitated primary care with then an ACO shared savings type wraparound? Or was it more, it wasn't a full global capitation?
No, it
Okay.
wasn't. So it's just it's a per patient per month payment. And of course, the docs all feel it's way too low, which is probably true. And then they say that there's shared savings, but we've never seen those shared savings. There's a lack of, sorry to be negative, but there's a lack of transparency in terms of data. I think once we have data, I'm hopeful that one day we can get the data so that we could actually see the impact of what our primary care doctors are doing upstream.
Yeah, one of the things Jack mentioned this morning was the idea that primary care PMPM is around $6 per month, and that really has to get up to $12 per member month, which enables the investment in the infrastructure so that primary care can really create, kind of the true care management that we've got to have. So really good stuff. Thank you. You want me to repeat the question, Dan?
Sure, go ahead.
Oh, God.
No, not really. I'm just messing with you. You're going to be nice to me, though, right? If I ramble, you're going to bring me back on? Yes. This is a complicated question for us. And working in an island, what I found, one of the things, many things actually found unique about the way we deliver healthcare is that we're many things to many people, and we have a lot of different types of services and systems to meet those needs. I mean, we have long-term care, we have rural health clinics, we have fee-for-service, we have specialty clinics, and we have a confined population and a very poor population. And so what does all that mean? How do you fit value-based care in that equation, right? That's not really that easy. Rural health clinics are primarily paid on a face-to-face fee-for-service model, right? And so rural health clinics and their enhanced payments have enabled us to really grow many different services. So how do you pull yourself off of that and somehow structure value-based care, often which is where you're incentivized to hold costs? So here's the thing that's a little bit of a philosophical question. If you have poor access, you have low spend. Let's just not forget that. You have low spend. And if you have low spend and you're in a value-based contract and you want to hold that spend there and you get a piece of that savings, that's fine if you have easy access to service and everything you need, because then you want to just control your costs. But what if you don't? So what you're doing is, in my opinion, a bit artificially holding at a level that's not maybe right for the people that you serve, right? So until you fix the access to care issue, until you make it where someone who has heart failure and has never seen a cardiologist actually can see one in their community, and by the way, spend the money that that takes, then let's talk about value-based care. So I understand that's maybe a little bit volatile because I think the industry and healthcare is moving to that direction, and we do want to be efficient with our monies. But here on this island, we have to fix one thing before we fix the other. So a big part of our strategy is to make sure we have services here that properly serve our community, and also focus on how efficiently we do that, the quality of the care we do. And then, to me, that's real value. So that's our philosophy.
No.
Answer.
Thanks, Dan. Good stuff. So the next question, I'm going to set up the next question with going back to this morning. When we talked about that fee-for-service payment system, right? When form follows function follows payment, and how a fee-for-service payment system where a provider or organization acting individually can affect its own volume, price, and utilization. And the form we evolved out of that was essentially less collaboration than more collaboration. And as the payment system evolves over time, and who knows what's the time frame we're talking about, that the need for collaboration to care both upstream, downstream for your patients, across the, primary care, specialty care, hospital, post-acute care, hospice, and other, public health and all of that. The need for collaboration to care for an entire community is significantly more. So the question I want to ask our contestants here, starting with Stephanie, we're going to go to the middle now, is, do you consider collaboration with other healthcare providers or insurers, entities, an important part of your strategy?
What do you think? Yes, of course.
And how so? Just give some examples.
So I think everybody wants to see their families and communities thrive, right? And that should be our North Star. That's what we should be rallying around and figuring out what we need to do, because we all come to the table self-preservation, right? How do we keep Stephanie or North Hawaii whole, HHSC whole, everybody else whole? And we may be able to achieve that, and we may not. But what give and take do we need to do in order to reach that North Star?
So my answer is an absolutely.
Okay. Good.
And I miss a couple things. I want to make sure that I call this out because it's so important, and it'll demonstrate is that at Kaiser Permanente we really it is a critical part of who we are is to engage with our community partners. And I'll give a couple of examples just with our COVID work with Community First and the vaccine efforts, with a couple initiatives that we have to provide support. So it's the Ho'ala Veterans and the Hawaii Institute for Pacific Agriculture for providing meals to people in geographically challenged areas, or HOPE. This is a respite that they provide for homeless who are receiving medical care. And then one I'm really excited is partnering with David here is providing mental health. It's the workforce accelerator program, and these are partnering with the university. So not just healthcare, with the university, growing our own. We have to invest in that. And that is where we have social work students who will be doing clinical rotations. So shout out, thank you so much. But we in rural health, we cannot individually be everywhere, cover everything, and do it alone. We have to. We have to partner. And I'll give an example is care coordination is a very, very big thing right now. And we have partnered with Dan and Clayton where we actually have case managers within their hospitals that when our members arrive in the ED, that they have care coordination to get the right place, the right time, and by the right person. And so can you imagine a 50-year-old male who is having chemotherapy treatments that goes weekly to Hilo emergency room. And now we have leveraged technology through HHIE where they'll get an alert that this member is in the ED. And that member doesn't need to be in the ED, but they're dehydrated and they need to be in the right place. And maybe it's just IV therapy in a nurse treatment center closer to home. And so this, I think, is the power. These are the specific examples that we start slow to go fast. And it's just doing these simple things. But for us, care coordination is top of our list.
Thank you. Susan? I'm going to mix it up on you guys.
First of all, I think for us, the partnering with HMSA very closely is critical. We are very dependent on them. Our IPA, our association, would have never existed without HMSA supporting it. And 60 to 70% of our revenue comes from that one source. So that's one thing that's extremely critical. And then all of the other, hospital and HHSC, Hilo Benioff Medical Center, and so forth, better communication, because I really see a lot of administrative burden, a lot of waste in terms of coordinating care between the various entities. And even, with Queens, sending patients there for specialist services or hospital services. There's a lot of paperwork. We're trying to streamline that, but still a lot of work to be done.
Thank you. Fantastic.
I love this because I am all about collaboration. If anyone has any great ideas, I'd love to talk to you because there's always opportunities, especially where we live. So we're always open to that. And I think one of the greatest opportunities we have, let's just think about this. What is the greatest assets that we have within our organizations? That's our providers and our staff. And I think that there's opportunity there. What's very difficult for us is to hire a specialist, let's say, and maybe that specialist just doesn't have the volume. So I think there's future opportunities to start looking at. Is there now a specialist you want to bring to solve the issues that we see in the community that can share those services between multiple organizations? And so I'd love to see us evolve to that more. We're having some discussions where that's possible. So I think that is a huge opportunity for us. And yes, absolutely, collaboration is everything. That's all we have. I mean, when things get tough out here, we have to start leaning on each other.
Awesome. Before Richard answers, I'm going to read the question again for those of you in the audience that have forgotten. So the question was, do you consider collaboration with other healthcare providers an important part of your strategy? And that's what we're answering right now.
Yes.
All right.
How's that for brevity? No question about it. And we need to be thinking outside our four walls. And I think some of the examples you were giving had to do with, it's not just healthcare providers, because we are talking about impacting social drivers of health. And that's the other aspect, the other providers in the community, the social service providers, the community. And we need to be thinking about that as collaborating with them. We do a lot with the schools. We have school-based clinics, but to do that, we had to collaborate and build relationships with the schools. So we have 6 clinics, but we're 8 different schools, and to me, that's ultimately the future. But we also have to collaborate between us and build looks at those transitions of care. Since I'm on primary care, I need to look to the hospitals and how do we do good and smooth and efficient transitions of care because it's all about the patient, and it's ultimately about the patient. And if we don't, we have to exist for the patient, for the community, and get out of our own way and sometimes, and get outside of our four walls and look for win-win situations.
Thanks, Richard. And Dan, unfortunately, what I didn't hear is anyone talk about partnerships with nutrition, which means my registered dietitian daughter is still on my payroll. Dan, what do you got?
So I think you asked about, is collaboration part of our strategy, right?
That's exactly right, Dan.
Excellent. And you almost would want to say, just because it's one of those questions, you wouldn't dare say no. Of course I love babies. Absolutely. No. Bluntly, we're at an event sponsored by Community First, right? And the whole idea is that we all convene together to hopefully come up with ways to collaborate. But probably most importantly is to build relationships with one another, so when the need arises to collaborate or to fix a problem, we know each other. And our state is small. It really is a small healthcare community. And if you've worked here any length of time, you really know you can't get much done all by yourself, no matter what your size is. And if you think you can, and you pull it off that time, the next time you will wish you had collaborated, right? So absolutely, as part of our strategy, is bluntly because we're interdependent on each other. And as a taxpayer-supported organization, we need to be regarded as collaborative, as looking out for more than just our own interest. But on a more operational level, we can't function very well without the support of our hospice, our private long-term cares, our imaging centers, our independent physicians. I mean, we're all really in the same game, caring for the same people, and we all live here. So we're interdependent, and we have to be collaborative.
What was fascinating about what Dan talked about was this morning we talked about dependent, your 5-year-old. This is borrowing from Covey. Independent, your 18-year-old, and interdependent, your 26-year-old. And the fact that you cannot be interdependent until you go through the phase of independent. And what Dan was very clear about was interdependent relationships, which means that we're all independent, seeking that higher level of relationship, which is, I think, the cement of collaboration in the future. So we're down to 2 more questions, and then we'll open the floor. So who hasn't answered the question first yet? Clayton. All right. What are the biggest challenges that exist in your organization to advancing these kind of these new health systems of the future?
Real quick, Randy, I think our moderator's broken. Can we get a new one? I've known Eric for a long time, so it's when we look at the challenges that exist, it really comes down to access and resources, right? We can try to solve this, but unless we start growing our own and making sure that we can put buildings up, we can do all these different things, but the heart and soul of the building are the staff, the providers. And when we're seeing so many people exit the island because they just can't survive here anymore, we really have to start thinking outside the box. So I think the biggest challenge that we face, at least on the west side, is access. We have huge geographical challenges, just trying to get people to where they're within 60 minutes, that golden hour, to have the access. And it's all about equity. So to me, that's the biggest challenge that we're faced with right now.
Ditto. Access and resources, and financial resources, human resources, and time, which is, sometimes we don't consider time as a resource, but it really is, because there's so many other things and pressures. So to move to value-based, to do those programs, to collaborate, takes time. But when you're having to deal with the day-to-day issues of your system and you're delivering care, it's hard to find the time to do those things. So I think absolutely access. That's if we can't get the people in, we can't provide them in the access. And Dan, you said it right. If you have low access, you're not having the quality. So you have to bring people in and get them in. So that is one of our key focuses, is how to extend access in different ways. And it starts from, can they call you? Can they get in when they call? And then getting to see a provider if they have to travel. What are the other ways of giving them access through telehealth, or taking having staff go out to see them and do home-based care? So access is, I would agree.
So the question we're answering, thank you, Richard, what are the biggest challenges that exist to advancing these strategies towards population health?
So for me, for our organization, it's workforce. It's really investing in our people. I think COVID has caused a lot of us in this room and in healthcare to reevaluate what's important, what kind of direction they want, and what's value to them. And so we see a lot of people leaving healthcare. And so we need to stop this now, and we need to invest in our people and our framework. I think access geography is a challenge here on the island and in the state. The other one is leveraging the digital platform. It's not for everybody. And also the geography of the Big Island itself makes it a limitation. So how do we do that? And then making sure that everyone has the right and fair amount of communication that they need in order to get health care.
Thank you. Yep.
So I would agree with everyone, but workforce. So I think a lot of the work, and Richard said it too, there's the operations of running a hospital, and then there's the strategy of all the work that's outside of the four walls, which includes affordability. So I just met with Toby yesterday to talk about housing. How do we build more? There's no housing inventory in Waimea, right? There's single family homes that start at 1.3 million. And, my staff, our staff, all of you, it's not only in Waimea, it's throughout our entire state. And there's a lot of people working on it. And all ideas need to be fleshed out to figure out, it requires a lot of collaboration on what makes sense, who can afford what, and being able to be able to provide the support not only for our workforce but for our community, because it's just an added stress when we, because we take caregiver engagement surveys regularly, and it's stressful coming to work because you're carrying the burden of having to make ends meet every single day. And a lot of people work more than one job. And so affordability is a huge issue in our state.
Thanks, Stephanie.
I'm going to look at this from a slightly different angle, and that is when I see all of the issues, the ways that maybe we can save money, look at efficiencies and so forth. I mean, there's so much to do. And so I think one thing that we really lack is transparent data. To know how many patients are really out there, what are the access. I know there were studies done, but to get a little bit more granular in terms of what that is. What kind of unnecessary ER admissions, unnecessary hospitalizations we have? What are the costs of that? I don't think we really have good comprehensive data for this entire island by institution, by provider, by these individual entities. So that's one area. The second area, I think, is, I think we all intend and want to work together in different ways, but there are limited resources. And so, and we are all motivated differently in terms of our payment models. So until we get on the same page with a similar payment model, I think it's going to be very difficult for us to work together. And then of course workforce, and sometimes people say, well, you folks have a clinic, and then Hill Medical Center, they have their rural clinics, and there's FQHCs, and oh, you're competing for patients. And I said, we're not competing for patients. I mean, access is a huge issue. we are competing for the workforce. And because our, we all say that we're the underdog, we're at the, end of the food chain. So we can't pay our staff because we don't get the subsidies or the richer reimbursements that the other entities get. So that's where the competition is. And it's just hard to retain staff, period. But for us, it's a really huge challenge.
Okay. One interesting comment is that, I work with the hospitals, the rural hospitals in Massachusetts, and there's one on Nantucket and there's one on Martha's Vineyard. The Martha's Vineyard, it's a critical access hospital, and what they've done is they have a 3-stage master facility plan. The first phase is a $19 million investment in housing on the island, so that they can house up to about 64 people in the housing. Now, as a critical access hospital, they're running it through their cost report, which is a great thing. But I mean, that's one way that you take the bull by the horns and do something about housing. You can't wait. Oh, Dan. Oh, yeah.
It's been a long time. Should you repeat that question? No. I'll kind of take a financial tact on this, and maybe it's a little wider, I guess, view on it. But I think our biggest challenge is to truly create a stable and consistent financial system to support our organization. And I've been with the organization long enough where we have lurched from crisis to stable to crisis to this to that. And that variability makes it very difficult to make steady progress and improve things. And I think we've made some headway with honestly diversifying our risk and getting a little more involved in our federal programs, thanks to some knowledge we learned a few years ago. I can maybe give Eric a plug there. And also I think some of us have been doing more with philanthropy. So basically finding more ways to make yourself more financially resilient, because at the end of the day, fixing many of these problems is all about a business and about setting up systems and making investments that will pay and deliver services. And you have to have consistency so you can not only fix the problem in the immediacy, but build systems that stay stable so you're not constantly doing that 2 steps forward, 2 steps back thing. So for us, if we can get where we have a strong financial model and that it lasts a long time, I think we will really have made some progress.
Yeah, that's right on. I look at that as a key element of moving from dependent to independent, is having that financial stability that you're going to be around for 10 years so that you can invest 10 years out. All right. Last question. What does your vision of healthcare delivery success look like on the island of Hawaii? Who didn't go first? Somebody didn't go first.
The vision, the dream, right? That we have common standards of care that are measurable, key performance indicators across the board for all of the entities, and then one payment model. Also significant investment in primary care and patient education. Let's work upstream to work with our patients, be very patient-centered before the patients cost an incredible amount of money and go through a lot of pain and suffering.
So what does success look like in our organization? And really for the island of Hawaii, Kaiser Permanente will not be successful unless each of the individuals on the stage with me are successful. And that's how we measure that. We all need to be successful in this, and we need a partner. So having that community partnership, we also need to be financially viable. And so with that, we are really defining value-based care and making sure that we can leverage and do things differently. A couple of things I will point out is that, you had said it as well, is we have something in our organization called Primary Care Reinvention, we have to do things differently in primary care. We're exploring the use of mid-level providers, bringing back the old healthcare team, it's a multidisciplinary team, and really exploring having the right people do the right work. Whether it be in primary care or specialty, also exploring centralized services. So Get Care Now, RN Chat, different modalities of care. And again, we realize that there still needs to be that traditional office visit for certain members on the island of Hawaii and within the state. And so I think that's something that's really, really important. But so many things play into the part of us being successful, but the main thing is assuring that we continue with partnerships in the community.
You know, interesting comment about primary care, and we referred to it a little bit this morning, is that often in this fee-for-service world that so many of us live in, we look at primary care as losing money. So when an organization loses money, the first thing you do is cut costs. You constrain workforce. You cut their, from 2 MAs to 1 MA to a half an MA to cut the losses. And that combined with what we talked about, these challenges of the demands of the medical record on our primary care, the demands of the primary care shortage as an industry, the demands of population health initiatives on our primary care, we're going in the exact opposite direction. We should be investing in primary care. And to some degree, back to Jack's comment earlier about getting that PMPM from primary care to $12 is going to be, I think it's going to allow us to do that. So I really like that. This how do we invest in primary care, team-based care, engage them and really support them and don't burn them out. What is that, Nicole? Well, that's what Wall Street's going to do. We talked about that this morning, right? Okay.
Well, I think that from my standpoint, it's more providers, more ability to meet the needs of the community. That's what success looks like, right? But there's so many layers to this, right? When you look at it, success looks like I don't have to wait to get seen by PCP. Success looks like I can get a procedure done and not have to fly to Oahu or travel some vast distance to get that done. That's what success looks like, that care can be delivered close to home, and there's caregivers that are at every level of care close to home.
That awesome. Thanks, Clayton.
You took the words out of my mouth, Clayton. From the patient perspective, that's what it is. Isn't that success? It's seamless care from the patient perspective, that they know where to go, they can access it in a reasonable time. But to do that, we have to have all these other things. We have to have success, be supporting one another as providers. We have to have the financial stability and resources. We have to have the workforce and the training, and we have to have the technology to help do that. We have to have the data, and that someone's mentioned data, and I think we do have to do more about understanding the data and what's going on in the island and understanding the gaps, because that will help us move towards success. Yeah, thank you for all those things.
I guess what success looks like is, how do we address, the continuity of care? There's all the work being done in hospitals, sick care, and then everything outside of the hospital. So ideally, I love to see a world where social service and healthcare providers and those that are providing those wraparound services get paid for what they're doing. It's part of the payment model.
Nutrition,
very much so. Yes, nutrition. So access to healthy food. And I think even expanding it more, if you look at climate change and health, right, the intersection, what is our relationship? What is our kuleana to aina? There's so much work to be done there, and where does that fit into the payment model? Because that relationship is real, and it's grounding, and it impacts our health and wellness.
So when you go last with a question like that, Clayton,
you are the last of the last question. So
all right. then we're going to be here a
No
while.
pressure.
We'll be
No
here a while.
pressure.
Clayton took my easy answer, and then you took what was left. So at least, so I'm going to look at success from a different perspective. I think success would be is if you just pick randomly any patient or member of our community and you ask them, how's the healthcare on this island? And they go, it is fabulous. I can get it when I need it, and it's high quality. And thank God I don't have to go to Oahu anymore. That would be success.
That Dan finally got one right.
You won't be back next year. No.
So that is so sitting in front of you are some of the biggest resources we have on the island of Hawaii for healthcare. What I would want to do now is have you ask questions. These are some of our highest leaders here. This is a chance for you to ask them specific questions about either their own organizations or their vision or anything else. So we're going to open this thing up. We got 20 minutes, I think, for you to ask these folks questions. Who's first? Oh, right here.
Hi there, Laros, the president and CEO of the Kona Kohala Chamber. Many of you I know. But my question is about workforce development. So we were just in the breakout with Good Jobs Hawaii, which was excellent. Thank you very much. And we did hear from the Hilo Benioff Hospital and the programs that you have. Sounds great. I know of what Clayton does and Judy at Kona Community Hospital. But really, that particular breakout was one of the takeaways was about how all of you do internships or shadowing or plug people in. So my question to you is, what are you doing presently about plugging into workforce development? And do you have plans or grander plans for the future?
Of course, we have a number of very small practices in our cohort. So oftentimes you'll have like a physician and maybe an APRN, a couple MAs, so very small practices. So it's often difficult, to bring in those interns, but we have made an effort to do that. And so we've worked with the University of Washington, their PA program. We've brought in Jabson students. The challenge that we have is then the physicians will, I'm the administrator, right, will come to me and they'll say, well, I can't see as many patients today, or you need to give me extra administrative time. So it costs money, right? And often these programs don't give additional subsidies for us to do the training. Actually, our docs are more than willing. They actually love teaching and would love to mentor more students, but the challenge is working it into our operations.
Yeah.
That's a great question, Wendy. Thank you. And it faces all of us. I think for the Hawaii Island Community Health Center, we have residency programs. We have an adult dental residency program. We have a pediatric residency program, dental residency program. We work with PAs out of medics, PA school. But that's not enough. We have so many other people in this community who need jobs. And in healthcare is one of the better paying. So what we've started doing, and thank you, Marcy, for leading this effort, but it's working with the schools and career pathways. And she just sent me a message this morning about someone who came from one of the schools, shadowed, and as a result of that, wanted to come and do some other things. I talked to your daughter, Clayton's daughter, is interested in dental and dental hygiene. And I said, why don't you bring her over and have her shadow our dental clinic? We need to do more of that. We need to do that across the board. Um, we go out to the schools, Marcy talks to, we take it's not just medical people. There's business, there's IT, there's revenue cycle, there's all these other jobs that students do not know about. And because the high schools are required to have career pathway programs, we need to be tapping into those. Those are our friends and family members, and we need to be doing something. And we're doing a lot with that.
Richard, that is exactly, as I've traveled, I've probably visited 400 rural hospitals in my 27 years. One of the best practices I see, a good friend of mine runs a hospital in southeast Iowa. He has an 8-year development plan for his medical staff. So he takes expected retirement and he backs up 8 years and says, and what that does is it puts him right in the high schools to recruit medical staff. He's doing the same thing with nurses, but instead of 8 years, it's 4 years. So he goes back and it puts them right in the schools. He has no vacancies on his medical staff or his nursing staff in a rural town in southeast Iowa. And it's all because of the proactive effort he's done around recruitment. We don't all have to answer. If you got something to say, then say it. If not, don't.
I got nothing to say. No, I agree. I mean, so we have a nurse residency program. We're seeing success there. It's small, still growing. We had 10 in our last cohort. 9 of them all applied at Kona, so that's great. But we need to do more. You know, I would envision, my background, I volunteered at Kona Community Hospital in their ER. So I would love to see us grow the volunteer program, because what a great opportunity to bring people in that want to learn about healthcare. Maybe they want to do it, maybe they don't. So I envision us really growing that volunteer program as a means to bring highly qualified people through the organization.
Anybody else?
Yeah, I do. So just a couple things. I echo the volunteer program. So we have a really strong volunteer program at our main hospital, and the intent is to expand that out where they allow high school students to test the waters and see if this is something, a career path that they want to choose. But one thing I want to just call out is it's not just with providers, which we do have an internal medicine residency program. But it is also, we just piloted a medical assistant to LPN track. And we piloted 10 of these individuals where we had 9 on Oahu and 1 on Maui 2 years ago. And our intent was to have them partnered with Maui program. And then we provided the clinical rotation at one of our, as Kaiser as one of the sites. And to date, 10 of the 11 actually have passed, and we're going to track them through. Our next is to move into the outer islands, so that this would be for Maui and Kauai and the Hawaii Island, to have these medical assistants move into that license program. So the other important factor is the clinical rotation and experience is so many schools are competing, and they need to get good clinical, and that's a challenge.
Great.
I was just going to say, Taylor, do you want to stand up? So Taylor's in charge of our workforce development. So if you have any questions, go talk to Taylor.
Are you recruiting? Okay, let's jump to another question.
Eric, I was just going to say, if someone leaves Dan's hospital, comes work for us, I think that's a win-lose.
It is.
So I come from the perspective, if someone's coming new to any of these organizations, that's a win.
Exactly right. Or we grow them from our own. That's what I heard loud and clear, whether it's volunteer programs, high schools, it's growing our own is going to be our greatest ability to keep. All right, next question. Let's jump around a little bit here.
Okay, hello.
Yeah.
There's been a lot of emphasis today on the importance of primary care. And as a struggling primary care company on the Big Island, what do you guys have in mind to provide significant investment in primary care facilities, or how do you intend to help the collaboration so we can be successful and provide the best continuity.
That's what Jack's for. Jack already solved that. $12 PMPM for primary care. Oh, oh, oh. That's more than $12 PMPM. That's a keeper. You want to keep that one.
Making the referral process easier, taking some of these admin tasks away so we can provide care to more patients.
I just want to comment because we are in the heat of that right now. We have a lot of opportunity within Kaiser Permanente to do this differently. And it's what we're calling primary care redesign. And so it's really to lift the burden off of that primary care physician. We acknowledge that there's a lot of waste in our system and the way we do things. And it's about the right person doing the right work. And so we're not there yet, but there are a lot of things we're exploring. We have a centralized support team where we actually have clinical RNs taking emails. So when the patients are emailing the physicians, they actually do wonderful triage of these emails and they filter them, and only the true ones that need to go to the physicians go. And we've deployed it to all of our 19 clinics, but it's tough. It is. And that's only one lever. There's so many different levers, but it's doing things differently.
Yeah, I look at primary care redesign as another. It's a team-based care concept.
Correct.
And that team-based care, if you don't know what team-based care is, American Academy of Family Physicians came up with this 15 years ago, way ahead of its
Yes.
time. Research it.
Yes.
Anyone else have anything? Because I'd like to get as many questions out, and we only got about 10 more minutes. Anyone?
I want to just say one thing. So we did a healthcare team, primary care, about 25 years ago, and full circle, we're still trying to solve it.
Jeez. A couple more questions. We got these incredible astute group here.
Okay, so I just want to ask just a quick reflection on, you heard the ahead thing. I mean, it's not a panacea. It isn't, the solution to all our problems. But what's the possibility of ahead on the Big Island?
The possibility of the AHEAD program, which Jack presented on earlier today.
Let's talk. I think that's the first step. We're hearing more and more about it. Let's sit down and talk. I'd rather have a seat to try to figure out, okay, if this is really coming, how do we work together? Is there a collaboration possibility? I think that's the first step. Again, there's a lot to wade through, and it sounds like you're still doing a lot of that as well. So let's chat about it.
For 2 years, I was involved in the Pennsylvania global budget model, where Pennsylvania rolled out to about 18 rural hospitals a global budget model. And I think it's a moderate success with challenges. And so it'll be interesting to see if we can address, because the AHEAD program was designed essentially a lot like the Pennsylvania global budget model. So it'll be interesting to see, kind of if we're having the same challenges as Pennsylvania, or we can get beyond those.
I think from the primary care, Big Island primary care perspective, I mean, when I heard that this was going to possibly happen, we were elated, we were excited. But correct me if I'm wrong, I think the resistance is going to be from the hospital systems. And I may be wrong, but I don't know if you want to comment.
But see, here's where the devil's in the details. And this is my learning from Pennsylvania, and then I'll let Dan talk, because a lot of people don't know this. So in Pennsylvania, the hospitals get a budget based on prior year's cost or prior year's revenue. But what happens is if there's shifts in market share, planned or unplanned, market share changes either adds or subtract revenue from the global budget. So you can still be a hospital with a global budget, and to the extent you add an orthopedic program or a cardiac program, your budget would be expanded to accommodate that. And a lot of people don't know that. That was one of these devils in the details that people don't understand. Now I'll let Dan talk.
So I think Clayton's wise beyond his years. That was a great answer. Let's talk. Let's talk. I mean, I've actually expressed this to Dr. Lewin. I think the concern certainly is that if you have global budgets, if you start low, you stay low. I mean, that's kind of an oversimplification. And some of the discussions about raising the Medicare base rate, about the Patch Act, there are many different things that could, quote, get the access to service where it needs to be. And then it is a rational discussion where you have a predetermined inflation adjusted growth of your services and you have to live within that budget, right? We all do that with our own budgets. But if you're poor and then you go, hey, you guys are going to always be poor and you'll incrementally get a little more money every year and be happy. I don't think any of us would be happy with that. So I think the concern is with the head is that two issues have to be addressed at the same time. And there maybe is a little skepticism that, you know, the federal government, where Hawaii is just a tiny little piece of it, and CMS and others would truly address the cost side of it, or excuse me, the access side of it, along with addressing, you know, the growth side of it. So I do think we should talk and keep an open mind, but it's got to be both.
Yeah, one of the challenges that we found in Pennsylvania was there was a lot of effort around, okay, look, if we can work together, improve our disease management, diabetes, COPD, these types of things, that we could really start to reduce the costs. But what happens is reducing claims costs is very different than reducing costs in a hospital. To essentially 85% of a hospital's costs are fixed or step fixed costs. So if we take one patient out, the claims cost might be $10,000 from the insurance, but the hospital cost savings may be $1,500. And so it's a really interesting when we start separating and talking about true cost, fixed and variable versus claims costs. They're wildly different. Maybe way in the back. We go way to the people in the back.
Eric, okay, great. Back here in the cheap seats. Back to the question of what does success look like? I'm going to suggest one thing, that success does not look like what recently happened in the HPH Hawaii Pacific Health nurses strike in Kapiolani. One of the issues was appropriate staffing ratios between nurses and patients. And during the strike, HPH gave a take it or leave it offer, in which they said either you accept our offer or you lose nurses, you lose your own healthcare coverage. Now, that kind of, you're all healthcare managers. Those kind of bargaining tactics are outrageous to the community. The message is unbelievable that a healthcare organization would do that. So I would turn the question of what success looks like. I love the idea of looking at what's great in the future, what we can change and how we can improve. But let's learn from our mistakes and make sure that we treat our employees fairly and we don't do these kind of outrageous, as some of you will be dealing with nurses contracts coming up, or employee contract, labor contracts, CBAs coming up. Let's make sure that the message we send to the community is one of caring. We're a caring industry, aren't we? We don't treat our employees that way. So I just wanted to share that and humbly ask you to consider that.
Last question. We're running out of runway. Oh boy.
So I'm a midwife, and I'm sitting amongst healthy moms, healthy babies, outreach folks who take care of families and babies, trying to keep people healthy. And I'm looking at a Health and Human Services Office of Inspector General report. The United States is experiencing a maternal health crisis with worse outcomes here than in any other high-income country. Significant racial and geographic disparities exist in maternal deaths. and complications. Access to maternal health care influences these outcomes.
Question?
Big question. What are you doing regarding the maternal health crisis?
Those numbers are bad, aren't they? Yep. So I think, like a lot of statistics and numbers, you have to look in the details of the numbers and what parts of the population have those poor outcomes, right? And I think if you look through them on this island and probably in other parts of our country, they're disproportionately where people have poor access to care. They may be financially disadvantaged. There may be second language. I mean, you can go through the whole list, right? So to get to that, you have to get to those issues and you have to acknowledge them and then address that particular population. So if someone has poor maternal and fetal outcomes because they live in Ocean View and they don't get any prenatal care and they show up when they're, I don't know, at 7 and they're ready to go, and who knows what potentially has happened before then, well, there's your issue. But the issue to fix perhaps isn't the maternal part, it's the outreach and addressing the needs of that community where they feel connected enough with the health services to get the prenatal care in the first place. So what we found when we really look at these issues and so forth, sometimes maternal is just the bellwether of all the other stuff, right? It is. And so I think if we look at it systemically, we should look at those populations with poor health outcomes and do systemic fixes for them. And then you don't just fix their maternal, you fix their diabetes and their lower life expectancies and other. So I think that's the tack that we're taking. And of course, there are some specific things related to maternal health as well.
Uh, okay, I was thinking I have a question in the audience. Okay, I forgot to mention that I'm also involved in healthcare. I am from Hawaii Care Choices, also known as Hospice of Hilo. So it's really great that we are here to hear the different aspects of healthcare and how we as hospice would love to be collaborating with our panel right here. So thank you, folks. Thank you very much. Thank you. Let's give a big hand to our moderator, Eric, and our wonderful panel. Thank you, everyone. Thank you. It's my great pleasure to welcome back onto the stage for our closing remarks for today's wonderful conference. In fact, give me the applause on how did you folks think today's conference went? I hope all of you do plan to join us at the networking reception. That's right after this, right out in the breezeway. I hope that you folks will plan to join us. I'm so impressed to see how much people are still here because normally after lunch, I'm asking everyone to move forward because, the whole back is empty. But man, you guys just hung strong. And that's because you folks stayed. Ayo! Very good. Handing it on over. Here you go.
Thank you, thank you, thank you. Earlier this morning, Eric spoke about his daughter who's in nutrition and that in her mid-70s, she was still on his payroll. And it triggered a memory for me because back in 1970, after 3 semesters at the University of Hawaii, I dropped out. And my father, who was a very large Hawaiian man, who in 1970 could have handled his disappointment in me in multiple acceptable ways. Yeah. And at that time. And what he did was he said something. He said, you know, you would make a great astronaut because right now in this home, you are taking up space. Okay. And four days later, I had a job, and the rest is history. Let me, I've asked the team in the back to help me with these images, and I've got a couple of them to help bring this to closure and provide some kind of a context for the theme of facing our future together, which I believe this is my second year, like all of you, frankly. And I was touched by this particular theme because it raises the question, what is it that we're facing? And it may be easier for us to understand what we're not facing. This room has decided that we're not facing status quo because status quo is not acceptable and is not sustainable. And what we're beginning to see 2 years into it is that a vision is coming together, much like a tapestry. Because your industry, our healthcare industry on the island, is very complex, it is beyond the capacity for somebody to unilaterally make a decision that is going to move it to where it belongs. And today, in the breakouts, in the panels, we're beginning to see with greater clarity certain aspects of a vision coming together, much like a tapestry. And the importance of this is that a coherent vision will unto itself create a gravitational pull that will pull us into a place that we desire to be. Earlier today, I used this image when Kaniela and Anna and the Akaka family put this conference on the right track with the opening pule. And I talked about a vision that came in the form of 3 elements: the air and its atmospheric conditions that allow you and I to see the rainbow, the moon bowl, because of water and light. Air, water, and light. What I'm here to affirm is that a vision was created for this island by somebody on the first canoe who made the discovery, who was given the responsibility not to name the state, but to name this one island. Ha, the breath of life, Vi, the fresh waters of life, and E in reference to the spiritual dimension, cosmic energy, right? Going back a year when the events that occurred at the opening with Danny Akaka, we together in this room, utilizing an ancestral tradition called La'aukahea, asserted a vision that he would receive the necessary help. And I referred this morning to the fact that he was fortunate because there were doctors at this first table who were tending to him and providing him the best health care. And you and I were able to get together and collectively, through the tradition of La'aukahea, create a vision that he would be healthy. And in the year and 5 days that has since passed, he and Anna have been not only united in this effort, but inspired by it. It wasn't until July that I called Randy Kurahara and I said, Randy, that video of what happened to Kaniela, it's time for him to see it. And it helped put together all the missing pieces that he had in his mind. And so this morning, when he was back here to thank you, it's because he understood that you were responding, we were responding together first on a spiritual level. And that level of spirituality created a vision that had a gravitational pull that saw to it that he got the best of healthcare, notwithstanding the full support of Mark and Lynn Benioff every step of the way. Next image, please. This photo is back in 2015. Okay, I had asked for this lunch because I wanted to understand why Gordon Moore was making the substantial financial commitment through his foundation in the 30-meter telescope. And then I realized the gravity and the magnitude of being in the presence of these two innovators. It was 2015, the 50th year of Moore's Law. Okay, Moore's Law, every 2 years, the capacity of the chip would double in half the size. When I dropped out of the University of Hawaii, the computing capacity of this took a room this size with hardware to compute. The reason it got to this is because of Gordon Moore. Okay? And these two men, as accomplished as they were, and both have since passed, chose to live their final years here on the Kohala Coast, in large part because of their belief that this island had certain qualities to it that made it healthy. And they spoke about that, right? And I listened to Gordon Moore that day at lunch grumble to Earl Bakken. Earl was the co-inventor of the pacemaker, right? At the time this was taken, a pacemaker was being implanted in a human being on the planet every 20 seconds. Okay? And I listened to the two of them complain about the fact that bodily fluids were eroding the chips in Earl's pacemaker, right? And what a challenge that posed, not only to creating a solution for that, but how it opened up Intel to all this exposure for medical liability, right? But being in the presence of two men who were on parallel tracks and changed our way of life, each with a vision. Earl's, inspired of all things by the movie Frankenstein. Okay, as a young man, he watched Frankenstein and became convinced that as an electrical engineer, there would be ways to help elevate the quality of life. And Bourne became what we know today as biomedicine, and why Minneapolis emerged as a center, as a world capital in biotechnology. Okay? Sitting there with them, I was reminded that the power of that vision has a gravitational pull that can help manifest the kinds of outcomes that we seek. Next image, please. Waipio Valley, okay? And this is what's so important culturally, that we pay attention to the names. Names like Hawaii. You don't just come along and then all of a sudden, at a board meeting, change it to big. How do you go from air, light, water to calling it big? And in doing so, you marginalize and dilute and frankly insult the mana that is in that name. Waipio Valley, 30 years ago, we're in there to help the taro farmers renegotiate their lease. Now, I may trace my ancestry, like many Hawaiians, back to Waipio Valley, but I come at that time from Honolulu, very aware that I am a foreigner in that valley. Okay. And so we spent quite a bit of time there getting to know the farmers, getting to know Waipio Valley. And so one day, Waipio means the curving water, the arching water. And so one day this young woman says to me, "Hey, John, see that waterfall? That's Waipio, the curving water." Okay. Come back. Several weeks later, young man has me up on a promontory and we're looking at the stream that courses its way on the floor of Waipio Valley to the ocean. And if you've seen that stream, it curves all over the floor. So he points to me and he says, "John, you see that? You see how the water curves in the stream? That's Waipio." Okay, I got it. Go back a month later. This time I'm with a kupuna, wahine, an elder. And she says to me, "John, you see the waterfall? It hits the floor and you see the stream, flows to the ocean, it evaporates, condensation, rain, waterfall," right? And so in her description, in her translation of Waipio, she is referring to the natural cycle of water, which thus is the natural cycle of life. Okay? The difference between the kupuna and the two young ones, everybody was right. But the difference between the kupuna's interpretation and her vision of Waipio Valley is she made the invisible visible for me. And thus, I was able to comprehend the full nature of that curvature, that this was what. Okay. My point for even raising that is that this organization and this conference is on a track to get that kind of clarity in a vision that is worthy of an island that is named after breath, water, and spirit. And we should settle for nothing less. Okay? And my last slide, please. Let me bring it home with this. Facing the future together. Before this canoe disembarks on its voyage, the lead navigator, Nainoa Thompson, who I've known since he was 12, we all kind of grew up on East Oahu. And I said, Nainoa, after all the training and all the planning and all of that, what's the final thing that has to happen before it's time to set sail? And he said, we must have clarity of vision and trust. We need to be able to see the same thing, and in their language, they actually talk. On their way to Tahiti from Hawaii, they actually talk about pulling the island out of the ocean. That's the clarity they have in their mind's eye of the vision at hand. But ultimately, everybody on that crew and everybody in this room needs to cultivate trust in order to succeed. That's what the future is about. That's where this organization is heading. That's where your participation in this is so vital. And on that note, a close friend of mine said, "How come you're speaking at a health conference?" And I said, "Well, at the moment, being the head of the Mauna Kea Authority is the most unhealthy job one can have. But I'm enjoying every moment of it. And with that, in your attention, thank you."
I'd like to call up Randy Kurhara for the final farewell for this conference in this room as we head out to the breezeway next.
All right. So, once again, how's about another round of applause for Lonnie for doing such a great job as our MC today? So again, I'd just like to mahalo everyone. I hope that you leave here with a sense of optimism for our future, but also realizing that we all have kuleana, or a role to play in making sure that our people are healthy and have access to quality health care when needed. Mahalo to all of our sponsors, our presenters, our partners, and our planning team for making this conference so successful. We also want to mahalo and aloha the Western Opuna team for this amazing venue and their service to us here today. But most importantly, we want to mahalo you for being here. So please take part in our networking reception to follow. It starts as soon as we're done here. And again, thank you for your time here today. We look forward to continuing this discussion. We have those of you that have signed up for our planning meeting tomorrow. It's at 8 o'clock. And if you have any questions, please see any of our team or our staff at the front desk. But anyways, thank you again, and we'll see you next year. Aloha.